You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 6th, 2019. This week I'm going to do an ESC wrap-up, and it's likely going to spill over into next week as well. I want to first start by saying thank you to Hannah in the Czech Republic, who came up and said that she listens to the podcast, and it was really nice to meet you and other listeners. So thank you for listening. Let's start this week with the DAPA heart failure trial. Now, the reason the DAPA heart failure trial was the biggest news coming out of the ESC meeting in Paris was not a relative risk reduction or an absolute risk reduction or an NNT. It's because the results of the dapagliflozin in heart failure with reduced ejection fraction trial ushers in a totally new way to treat patients with heart failure, a new paradigm, if you will. One of the most overused words in clinical science is game changer. Well, the marked reduction in heart outcomes, heart failure hospitalizations, CV death, overall death, with the SGLT2 inhibitor drug dapagliflozin may indeed change the game of treating patients with heart failure with reduced ejection fraction. I've got a column on this trial. My colleague Melissa Walton-Shirley has one, and there's an excellent news story up as well. SGLT2 stands for sodium glucose cotransporter. These drugs block the reabsorption of glucose in the proximal tubule, and in patients with type 2 diabetes, they've been shown to induce weight loss, diuresis, and have a renal protective effect. And most importantly, they reduce outcomes, including the prevention of heart failure. Now, the question the authors of DAPA heart failure asked is whether they could improve outcome in patients without diabetes. I mean, more than half the patients in the DAPA heart failure trial did not have diabetes. And the trial enrolled typical heart failure with reduced ejection fraction patients. They excluded patients with GFR less than 30 and type 1 diabetics. There were about 2,300 patients on dapagliflozin and about 2,300 on placebo, and the background medical therapy was excellent. And the results, both components of the primary endpoint were significantly reduced. CV death was reduced by 18% and any worsening heart failure event by 30%. The Kaplan-Meier curves for the heart failure endpoint separated within months, suggesting an early benefit of dapagliflozin, likely due to its diuretic effect. The benefit was consistent across most subgroups, notably those with and without diabetes and those on or off ARNI inhibitors. All-cause mortality was also reduced, the hazard ratio 0.83, and that was nominally significant. Now, this degree of risk reduction, to put it in context, was comparable to recent heart failure trials, including the Paradigm heart failure trial, the Emphasis heart failure trial, which was eplerenone, and SHIFT, which was ivabradine. Also, the adverse events in the trial were overall similar. Now, the paper is not yet out. We need to be cautious, but these are striking results. Let me discuss 4 potential headwinds with these drugs. First, the learning curve. At first, this learning curve will be steep. I mean, I've never prescribed this drug. Cardiologists are going to have to get used to it. Second headwind is polypharmacy and pill burden. Patients with heart failure already take lots of medications, and here is another. Many patients will push back against taking this many pills. We also have to be very careful with translation to patients who have comorbid conditions. Remember, trial participants tend to be less sick and do better than patients in the real world. And finally, there's the cost issue. Remember that ARNI drugs, sacubitril valsartan, they're expensive, but doctors can still inhibit the renin-angiotensin system with ACE inhibitors and ARBs, and these are much cheaper. We won't have that substitute for the SGLT2 inhibitors. Second trial to talk about is the Paragon heart failure trial. Now, the victory here would have been ginormous. Millions upon millions of people suffer with heart failure and a preserved ejection fraction. But it was not to be. In Paragon heart failure, sacubitril valsartan did not do better than valsartan in reducing the primary endpoint of all heart failure hospitalizations and CV death. Now, the key inclusion criteria, the authors did a great job enrolling patients with true heart failure with preserved ejection fraction. Patients had to have an EF greater than 45, elevated BNPs, and they had to have some sort of documented structural heart disease. The trial followed patients for 35 months. There were 894 primary endpoint events in the sacubitril valsartan arm and 1,009 in the valsartan arm, so that's 12.8 versus 14.6 per 100 patient years. This corresponded to a relative risk reduction of only 13%, and that did not meet the statistical threshold of less than 0.05. The p-value was 0.06. However, crucially, the numerically lower primary endpoint events was due to heart failure hospitalizations and not cardiovascular death. Now, similar numbers of patients stopped taking their study drug during the trial, but hypotension, low blood pressure, occurred more often with sacubitril and valsartan, as did angioedema. Angioedema was 3 times more likely in the sacubitril valsartan arm, 0.6 versus 0.2%. There was also talk at ESC about 2 subgroups that did better on the sacubitril valsartan, and that is women and those patients who had an ejection fraction in the lower range, from 45% to 57%. Now, the problem with the subgroup analysis is that the overall trial results did not reach the statistical threshold. Given the potential market of patients with heart failure with preserved ejection fraction, it's going to be important to be ready to counter the spin on this trial. Now, one spin is that the p-wave was so darn close. Here, I say it doesn't even matter. If the p-wave was 0.04, the interpretation would be the same. And the main interpretation is there was still not a reduction in CV death. And the authors chose all heart failure hospitalizations instead of the more typical time to first heart failure hospitalization. This sounds like it's in the weeds, but all previous heart failure with preserved ejection fraction trials chose the time to first heart failure hospitalization. And to the author's credit, in the supplement, they show the results had it been analyzed that way. And if you analyze the Paragon heart failure trial in the way that other heart failure trials were analyzed, the hazard ratio here is only 0.92 for the primary endpoint, so less impressive. Now, another issue, despite careful run-in periods, which enrich a trial with healthier patients, and again, this is not a bad thing, hypotension was more common with the sacubitril valsartan drug, and this would surely be worse in the real world. I don't think that sacubitril valsartan for heart failure with preserved ejection fraction clears the bar for using this drug. Finally, I may get in trouble for saying this, but I'm going to say it anyways. I can't help but wonder how paradigm heart failure would have turned out had sacubitril valsartan faced the high dose of valsartan used in this trial rather than the medium dose enalapril. Third important trial from ESC is the COMPLETE trial. About half of all patients who present with STEMI have multivessel coronary artery disease, and what to do with these non-culprit stenoses has not been clear. The 2 choices, obviously, are to fix the culprit lesion and treat the rest with optimal medical therapy, and the other is to do a complete revascularization, hence the name of the trial. Now, intermediate-sized RCTs have suggested that complete revascularization is safe and it reduces the risk of repeat revascularizations when compared to culprit vessel PCI alone, but these previous trials were not powered for hard endpoints, and even a meta-analysis of these trials was inconclusive. So in complete, about 4,000 patients with STEMI and multivessel disease were randomized to complete revascularization or culprit lesion PCI alone. Randomization was up to 72 hours after the STEMI intervention, and operators had to specify whether they planned to do the repeat procedure during the inpatient stay or as an outpatient if patients were randomized to the complete revascularization group. And about 2/3 of the complete revascularization group had the second procedure within 72 hours, and 1/3 of it had it after discharge. And the trial had two co-primary endpoints. One was CV death plus MI, the other was CV death, MI, and ischemia-driven revascularization. So the first primary endpoint, CV death and MI, was significantly lower in the complete revascularization arm, 7.8% versus 10.5%. The absolute risk reduction was 2.7%, but this was driven by lower rates of non-fatal MI. Cardiovascular death did not differ significantly, 2.9 versus 3.2%. The second primary endpoint, which was CV death, MI, and revascularization, strongly favored a complete revascularization, but again, this was driven by a whopping 6.5% lower rate of ischemia-driven revascularization, and in relative terms, this was an 82% reduction. Death from any cause did not differ with either strategy, 4.8 versus 5.2%. The subgroups looked consistent. The benefit of complete revascularization was consistently observed whether or not the staged procedure occurred as an inpatient or later as an outpatient. Now at ESC, this trial was lauded and described as practice-changing, but I want to push back on that. Okay, for sure, it was a positive trial, but there is a lot of nuance here. While the internal validity of the trial looks robust, there's much to say about the external validity of the trial or its translation to practice. In the accompanying editorial, Drs. Kober and Engstrom do a nice job of highlighting who these patients were in complete. They start by making the general point, again, that patients in clinical trials tend to be healthier and do better than those not in trials. Specifically for complete, they noted patients in the complete revascularization trial had a relatively low syntax score, which is a measure of the complexity of the CAD. Thus, complete revascularization does not apply to patients who have gnarly CAD. There were no patients in complete who had cardiogenic shock, and previous coronary bypass surgery was an exclusion criteria. Now, taken together, these points argue for very careful application of this evidence in the real world. Another important nuance is that the driver of the positivity in complete was non-fatal MI in the first primary endpoint and ischemia-driven revascularization in the second. Reducing MI is a good thing, but avoiding an MI today in the era of high-sensitivity troponin is much less significant than avoiding it years ago. And ischemia-driven revascularization in an unblinded trial is about useless. If patients knew that their culprit-only treatment means they are walking around with potential time bomb lesions, that can certainly drive repeat revascularization, and I would call this classic subtraction anxiety. Finally, my friend Jay Schloss asked me on Twitter whether a positive complete trial counters the current evidence that stenting coronary disease does not improve outcomes, especially since the complete Kaplan-Meier curves seem to continue to diverge over time. I would say that this does not, because these are still STEMI patients. Also, the signal of benefit is pretty small since it's driven by non-fatal MI, which is not nothing, but surely not the same now as it used to be. I would argue that if the MI reduction was so significant, why does it not drive a lower rate of cardiovascular death? Another important trial from ESC was on secondary mitral regurgitation. Last year, two MitraClip trials for secondary MR went in different directions. The Mitra FR trial showed no benefit, and the American COAP trial showed dramatic benefit. One reason offered for the difference was different follow-up periods. Mitra FR had only 1 year and COAP 2 years follow-up, and the COAP authors told us that remodeling from fixing the mitral regurgitation takes time, and indeed you would expect benefit to accrue over time. And in COAP, the Kaplan-Meier curves did seem to significantly diverge after 1 year. So at ESC, MITRA-FR investigators presented their 2-year follow-up, which was published in the European Journal of Heart Failure. And there was still no benefit from MitraClip. All-cause death and unplanned hospitalizations, which was the primary endpoint of MITRA-FR, did not differ at 24 months. Both components of the primary endpoint also did not differ when looked at alone. There was discussion at ESC about how the two trials enrolled different patients, and you've heard this before. There were more patients with severe MR, less pronounced LV remodeling, lower pulmonary pressure, and better RV function enrolled in COAPT than in MITRA-FR. The authors at ESC also spoke about and wrote about in their paper that a patient-level meta-analysis of the two trials is planned, and this, I think, will help shed light on the effect size and possibly tease out baseline characteristics that would help predict a MitraClip benefit. And once the ongoing ReShape 2 trial is finished, there'll be even more clarity on percutaneous mitral valve repair. Finally, ticagrelor had a tough meeting in Paris. First, let's discuss the non-industry funded study which was published in the New England Journal, and this was called the ISAR REACT 5 trial, prasugrel versus ticagrelor in patients who presented with ACS for whom an intervention was planned. 84% of these patients did get PCI, 2% to CABG, and the rest had medical therapy. Those ACS patients included both STEMI and non-STEMI, and there was a bit of difference with the loading regimens of the two drugs. The primary endpoint was a composite of death, MI, or stroke, and bleeding was the secondary endpoint. The trial was conducted mostly in German centers over 12 months of follow-up. A primary endpoint occurred in 9.3% in the ticagrelor group and 6.9% of the prasugrel group. That's a 2.4% absolute risk reduction, which easily met statistical significance, and each of the components of the primary endpoint, death, MI, and stroke, were numerically lower with prasugrel, but the primary driver of significance was fewer MIs. There was no difference in bleeding. Now, kudos to journalist Marlene Busco, who nailed the news story. And I love the comment from Dr. Ed Fry, an experienced interventional cardiologist from Indianapolis, who wrote, quote, "This study also underscores the importance of independently funded and designed trials." His point drives home the competing goals of industry and clinicians. In many cases, industry's goal to make profits are perfectly confluent with ours to help patients. But industry is unlikely to fund useful head-to-head trials of approved drugs because of the risk of losing. That's why you'll never see an industry-funded trial of an oral anticoagulation agent for AFib. And as appraisers of clinical evidence, we need not to think of industry as nefarious, but only to understand these dualities of interest. Finally, one of my interventional partners left me a very nice comment. She said, "Asking a patient to take a drug twice a day, ticagrelor, that their life depends on is absurdly optimistic." Okay, the second ticagrelor story and the other piece of rough news was the THEMIS trial, which was also published in the New England Journal of Medicine. THEMIS studied the question of whether adding ticagrelor to aspirin versus aspirin alone in patients who had diabetes and stable coronary disease would reduce the primary endpoint of CV death, MI, or stroke. Here again, the primary safety outcome was major bleeding. This was a huge global trial of 19,000 patients with 40 months follow-up, and the inclusion criteria meant that the patient had to have stable CAD, but 58% of the cohort had had a previous PCI in a distant past, still stable coronary disease. Permanent treatment discontinuation was more frequent with the ticagrelor group, 34% versus 25%. The primary endpoint was indeed lower in the ticagrelor group than in the placebo group, 7.7 versus 8.5%. That's an absolute risk reduction of 0.8%. And because the trial is so huge, that 10% relative risk reduction met statistical significance with an upper bound of the confidence interval at 0.99. Bleeding, however, was more than twofold higher, 2.2% versus 1.0% in the ticagrelor plus aspirin group. Now, I know that NNT and NNH have their limitations and some people don't like it, but here, just to review, The number needed to treat to prevent a major adverse event was 125. However, the number needed to harm was only 83. This is a clear wash, or it's a bit negative for ticagrelor. The Kaplan-Meier curves in the paper, even with the truncated y-axis, are nearly on top of another. Go look at that figure. What's more, the hard endpoints of CV death and death were not any different. But this is not it for Themis. The Themis authors have published another paper from this huge study, and this one is a subgroup analysis of those patients in the trial who had had a previous PCI procedure. This was a pre-specified subgroup analysis, and it's published in Lancet. Now recall that to get into Themis, you had to have stable CAD, and just under 60%, or 11,000 patients of the group, had had a previous PCI in the distant past. So here in this analysis, in patients in Themis who had had a prior intervention, the combination of ticagrelor plus aspirin looked a little better. For the major adverse cardiac outcomes, it was 1.3% lower in absolute risk reduction. That's 7.3 versus 8.6%. Here the hazard ratio is 0.85. That did meet statistical significance. And no difference in the major adverse outcomes for those who didn't have an intervention. Still though, cardiovascular death and overall death look similar. And major bleeding was still twofold more common with the combination. The authors did a net clinical benefit, and the combination came out beneficial in those who had had a prior PCI and not so in those who did not. On the surface, this makes sense, right? Because patients who'd had previous PCI are probably higher risk, but we mustn't forget that this is a subgroup analysis and that even though it's slightly more favorable, it trades about a 1% increase in reduction of major adverse cardiac events versus a 1% increase in bleeding. The net benefit calculations they did turns on what you put in it. One was non-significant and the other significant. And in summary, given the cost of ticagrelor, I don't think this data is strong enough that we should be routinely adding the drug to patients with type 2 diabetes who have stable coronary disease, and these patients are likely on bunches of other medications. Okay, so this is a little longer than the normal this week in cardiology. These are big trials and I wanted to give them their due. Next week I'll have more reviews on other important trials from ESC. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please tell your friends, consider subscribing and giving us a review. It helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.